Good evening. On behalf of Danny Hodges, Program Director of Cancer Support Community of Greater St. Louis, and myself, thank you for joining us at tonight's program, Bone Health and Cancer. I'm Debbie Bronstein, Program Manager of Sharsheret Supports St. Louis, which is a program at the St. Louis Jewish Community Center, and we're also a community partner of the national nonprofit Sharsheret organization. Both Danny and I are thrilled to be partnering on this very important topic. Before we begin, I want to take a moment to thank the team of experts that you're going to be hearing from, Matt Bruns, Kayla Pinkley, and Dr. Amy Hudson. We also want to thank Laura Skraska, a member of the Jay's technical team who helped put tonight together, and she's behind the scenes, so no pressure, Laura, but you're keeping us on track here. There is one housekeeping item. At any point during the presentation, you have a question, please type it into the Q&A box. Danny's going to be monitoring the box throughout the evening, and then she will moderate the Q&A at the end of the program. So anytime you have a question, please go ahead and enter it. So a little bit more about your host tonight. As I mentioned, Sharsheret Supports St. Louis is a program at the St. Louis Jewish Community Center and a community partner of the national nonprofit Sharsheret organization, headquartered in Teaneck, New Jersey. As a community partner, we bring the mission to the local community, which is to support and to educate. In terms of support, we have a plethora of free, individualized, and confidential programs available to women and their families who are facing a breast or ovarian cancer diagnosis. The other part of our mission is we educate the community, especially men and women of Ashkenazi Jewish ancestry, on increased hereditary cancer risks. And it has to do with their higher propensity to carry a BRCA gene mutation. And as we're learning, there are other mutations out there as well. So although 1 in 40 men and women of Ashkenazi Jewish ancestry carries a mutation, compared to 1 in 400 to 500 in the general population, so 10 times greater, knowing the risks about hereditary cancer is something we all have to be aware of because you find it in all ethnicities. So that's what we do. Also hosting tonight is the Cancer Support Community of Greater St. Louis, which is a local organization that offers support programs and services at no cost. They welcome anyone impacted by cancer, including those living with cancer, those with a history of cancer, friends and family members of those with cancer, and people who have lost a loved one to cancer. Cancer support community programs include individual counseling and group support, education seminars, nutrition education and cooking demonstrations, as well as healing arts programs such as writing workshops, therapeutic art, horticulture, sound therapy, gentle exercise, and social opportunities. It's a mouthful, they offer a lot. Tonight's discussion, we're going to focus on how to keep bones healthy, strong, before and after, during and after a cancer treatment. In addition to discussing overall bone health, our expert panel will share ways you can boost your bone health through nutrition and protect your bones through exercise and fitness. It is now my pleasure to introduce tonight's first speaker, Matt Bruns. Matt is a board-certified orthopedic nurse practitioner with SSM Health Orthopedics, specializing in helping people manage their bone health. He has more than 15 years of clinical experience in treating patients with bone health concerns. Matt sees women and men of all ages who are at risk for osteoporosis or a fragility fracture and works with their medical providers to determine the type of treatment needed. He works closely with patients to assess their individual needs to tailor a plan of care best for them. I'm now going to turn it over to Matt. And don't forget, if you've got questions, go ahead and enter it in the Q&A, and Danny will take care of it at the end of the session. Matt, it's all yours.
Thank you, Debbie. I appreciate the opportunity to speak to you all this evening about something that I'm very passionate about, and that happens to be bone health. As Debbie mentioned, I am an orthopedic nurse practitioner, so I do come at this from a little different point of view, as I'm not specializing in oncology. So I do see the negative effects of osteoporotic fractures on a regular basis in my clinic, and therefore I tend to treat osteoporosis a little more aggressively. So, as Debbie mentioned, I have a doctorate in nursing practice. You can go to the next slide. And I also have a special certification in clinical densitometry. So I have an expertise in reading and interpreting bone density to determine patients who are at risk and those who are not. Next slide. So the objectives for this evening, I want to define what is osteoporosis, who does it affect, how often does it affect them, what are the risk factors, a little bit about bone cancer and metastasis, the signs and symptoms to be aware of, people who are at risk, and also bone loss associated with cancer treatment, which is kind of an animal all to itself. And then the diagnosis and how it is completed and how it's performed, and then the available treatment options that we have. Next slide. So this is a picture of a bone biopsy. You can see on the left-hand side the normal bone, which is very thick, robust struts throughout. And on the right side, the osteoporotic bone, where you can see the small, fragile little pieces of bone and the trabecular part of the bone that we call, or these little honeycombs we call the trabeculae, become weak and brittle and subsequently lending itself to fracture. You can imagine that when a tumor or neoplasm is present, that then kind of it engulfs or eats away at this even more. If you kind of think about a ladder that you would climb with all the rungs and you took out about every other rung, how that would subsequently make the ladder more weak and unstable and put you at risk to fall as you tried to climb it. Next slide. And so osteoporosis is a major public health threat for 55% of people over the age of 50 in the United States. We know that about 10 million Americans already have a diagnosis of osteoporosis, and another 35 to 45 million Americans have low bone mass and are subsequently at varying degrees of risk based on their different risk factors and other health issues. We know that primary bone cancer is uncommon. It accounts for 2 out of every 1,000 cancer diagnoses, and it occurs more frequently in men than in women. Bone is the 3rd most common site of metastasis after liver and lung, and is most frequent in people with breast cancer and advanced prostate cancer. Approximately 70% of people with advanced breast and prostate cancer experience bone mets. Next slide. So we have some risk factors that are modifiable. Unfortunately, we do have some that are non-modifiable. We know that smoking is one of the worst things that you can do for the musculoskeletal system in general, and even greater risk as it relates to osteoporosis. Probably the worst next to alcohol or along with alcohol as far as modifiable risk factors. We know that low body weight also plays a risk. There's a phenomenon that happens in bone that when you load the bone with a force, there is a mechanism by which the bone becomes more robust or stimulates bone formation to make the bone stronger. So those folks who are of low body weight tend to be a little more at risk. Obviously, if your calcium and vitamin D intake is not sufficient, that's going to place you at risk. Again, excessive alcohol use. So excessive is considered 3 or more drinks a day on a regular basis. Fractures often occur as a result of a fall. The single biggest predictor of a future fall is a current fall. And the fear of falling is also an independent risk factor for future falls. So taking into account those people who are already having these issues, poor physical activity in general. There's a phenomenon or a thing that occurs called sarcopenia, where as you stop using your muscles and aren't as active, the muscles shrink and they lose their ability to become stronger over time, which subsequently places a decreased force on the bone and therefore doesn't make it stronger. Hormone deficiency, we know, is a tremendous risk and ultimately part of the equation with prostate and breast cancer, why people become at increased risk. Unfortunately, the non-modifiable risk, genetics, history of fracture, the single biggest predictor of a future fracture is a current fracture. So when that initial fracture happens, that should be sought as a kind of a red flag warning that there are more to come if we don't take care of the necessary take care of the necessary underlying osteoporosis. Women are unfortunately more at risk. As they become estrogen deficient, the risk goes up. As you go on some of the treatments for cancer, that suppresses the estrogen even more, and subsequently increased risk and advanced bone loss occurs. For every decade of life over the age of 50, there's an incremental increase in risk of fracture just with age alone. And then Caucasians tend to be more at risk for osteoporosis in general. Next slide. So these are just a couple of radiographs or x-rays of what bone cancer or metastasis looks like. So you can see on the image of the right, this is a picture of a femur. You kind of see this shadowed area that is being eaten away from the outside because of the presence of a bone tumor. And then similarly on the left side, or excuse me, on the right side, a picture of a humerus with a large metastatic lesion in the bone that has eroded through the cortex. You can imagine as that cortex becomes thin and weakened, how this puts people at tremendous risk. I actually have a personal friend who had an experience like this and kind of tossed her purse in the back seat of the car and snapped her humerus in two. And unfortunately, it was as a result of this metastatic lesion that was present in the proximal humerus up by the shoulder. Next slide. So signs and symptoms to be aware of, things to think about. Typically, these types of tumors or metastatic lesions create bone pain that frequently occurs at night. There's often swelling and tenderness near the area that's affected. I can tell you that in the handful of cases of neoplasms or cancer that I've diagnosed in the bone, they come in with a very kind of benign description of joint pain or extremity pain that until you get that initial radiograph, there may not be any other inciting injury or explanation for why the pain occurred. Obviously, the pathologic fracture is a huge hallmark in identifying these patients that are at risk. So pathologic means related to a specific disease. Oftentimes, it's pathologic is thought about just in terms of cancer or tumors in general, but pathologic fractures occur as a result of osteoporosis as well. Generalized fatigue or malaise, kind of low energy is a potential sign or symptom. Unintended weight loss is something to be mindful about. And then fevers and night sweats frequently occur in patients that are developing or have cancer or metastatic cancer. Next slide. So as I mentioned before, cancer treatment-induced bone loss that we refer to as C-TIBL is kind of another animal all into itself. Unfortunately, you are being treated to prevent the negative effects of the cancer, and unfortunately what happens is that bone loss occurs as a result. And so the current recommendations are in patients who are at risk, an assessment of your clinical risk factors, and obtaining a DEXA scan or a bone density scan, which we'll talk about in a second, is the gold standard diagnostic test for osteoporosis. It's also used to monitor the bone loss over the course of time and the course of treatment associated with cancer treatment. Weight-bearing exercise is extremely important. We know that weight-bearing exercise alone is not sufficient to reduce your risk of fracture, but weight-bearing exercise, in addition to approved treatments and other supplementation, can have a significant impact on bone strength. Smoking cessation is incredibly important. We obviously know in the cancer population, these patients are frequently smokers. Smoking is a big risk factor for cancer, but subsequently an increased risk for osteoporosis. Again, reducing alcohol intake or eliminating it is important, and calcium and vitamin D supplementation is encouraged. We also know that anti-resorptive therapy, which is one of the approved groups of medications used to treat osteoporosis, not only in patients who don't have cancer, but in patients who specifically have cancer, is recommended in women receiving either aromatase inhibitors or ovarian function suppression, or in men who are receiving androgen deprivation therapy for prostate cancer for more than 6 months, who have a bone mineral density of less or a T-score of -2 or worse, and or who have multiple risk factors, more than 2. So that's a lot to think about there. But as the bone density gets worse, or they have more risk factors, the risk for fracture significantly increases. Next slide. And so, as I mentioned, diagnosing osteoporosis is typically done with the gold standard diagnostic test, which is called a DEXA scan, or you may have heard as a bone density scan. These scans are typically very painless, very low X-ray or radiation exposure. You lie on a table and they take an X-ray basically of your hips and of your lumbar spine. And for those who don't have those regions imageable because of previous surgery or other extenuating circumstances, they can do a forearm bone density. And so the age for which you should get your first bone density, just based on age alone, is in women of age 65 or older, or in men 70 or older, and anyone over the age of 50 who have risk factors, multiple risk factors for osteoporosis. So if you're a man or woman over the age of 50 who has a history of smoking, alcohol use, previous fracture, parental history of hip fracture, history of rheumatoid arthritis, or history of chronic steroid use, you should have a DEXA over the age of 50 much sooner than the age of 65. Unfortunately, only 30% of women who should be getting tested are. And so this is a problem because statistically, 1 out of every 2 women over the age of 50 will suffer an osteoporotic fracture in their remaining lifetime. So it's pretty staggering statistics just based on osteoporosis alone, without taking into fact the exposure to cancer and cancer-related treatment. Next slide. So some treatment options are available. There are actually quite a few. They are becoming more and more robust. We have some agents that have recently come to market and have shown tremendous promise with reducing risks for fractures. We also know that nutrition is an incredibly important part. And I know that that's going to be discussed a little more in depth, but calcium and vitamin D supplementation are the basic recommendations for any bone health program. There are lots of other supplements that people are taking. The studies do not demonstrate that those are necessary. That calcium and vitamin D are the primary ones. Most of the other ones that are being taken, 1, probably don't need to be taken, and 2, most people get in their normal daily diet, therefore they don't need to be supplemented. As I mentioned previously, lifestyle modification, weight-bearing exercise, and fall prevention training are extremely important. We have a very good, dedicated bone health program with physical therapy, specifically to prevent fractures, falls, increased strength, balance training, extremely important. And then the medications are mentioned here, all work in a little bit different manner and different strengths and different dosing regimens. I won't
Laura, did we lose Matt?
Yes, it looks like we lost Matt, and we can, he said he was having a little bit of internet difficulty, and we can hopefully hop back to him at the end.
Okay. So we will navigate here onto the next speaker. We will thank Matt when he does rejoin us. And then we'll ask him if he wants to add anything that he didn't get to. So we apologize for that. So I am now going to.
We may have Matt back. Let me double check. Yes, it looks like we've got him. Possibly not. We'll let's
Sorry,
go ahead and
Laura,
go
I
back.
can't see my slides. I
Okay.
apologize for my technical difficulty.
No problem. Let me get you, get this shared again for you. Here we go. Yeah, it looks like Matt's having some connection issues, so we will go ahead and I'll go back to Debbie real quick here and we'll catch up with Matt.
Sorry, I can only.
At the end there.
Okay, so Laura, I'm going to go ahead and introduce Kayla.
Great.
All right, well, I apologize for those difficulties, but we will regroup. So now I would like to introduce Kayla Pinkley, who works at SSM SLU Hospital Cancer Center as the outpatient dietitian covering the radiation, infusion, hematology, oncology, and the otolaryngology clinics. And I'm smiling because I had to practice how to say that word, I'm not even trying to say it again. She works with a variety of patients that at times need guidance with more than just cancer-related nutritional issues. She acts as a mentor to dietetic interns working on their clinical hours to become future dietitians. Kayla holds a bachelor's degree in dietetics and nutrition from Missouri State University, as well as a master's degree in dietetics and nutrition from Ball State University. So thank you, Kayla, for joining us, and now I'm going to turn it over to you.
Thank you. Okay, thank you for introducing me, Debbie. You can go to the next slide. Thanks. So just to go over just a little bit, I had a little introduction thing that I put up so you guys can follow along. So first I'm going to introduce exactly what I'll be talking about, and then I'm going to talk about individuals with cancer who are more at risk for having bone health issues. The two main nutrients involved with bone health, recommended amounts for each of those nutrients, and then have an overall summary. You can go to the next one. So to introduce this, individuals who are going through treatments for their cancer need to make sure that they're getting adequate nutrition to help them while going through nutrition or their treatments. So instead of also just, as Matt mentioned earlier, calcium and vitamin D are very big parts of it, which is the main thing that will help you overall with bone health, but also making sure you're getting enough calories, making sure you're getting enough protein during treatments to make sure that you're strong enough to go through them. A lot of patients that I see do have issues with getting adequate calories, and so that also causes weight loss, which potentially can interfere with bone health too. And so it's just really important to make sure that you're getting adequate nutrition overall, just a huge amount of it. And when I follow my patients, I see them very closely. I watch their values of everything they're going through. I see how often I need to follow them, if they have any weight loss, what's going on with them, and treat them the best that I can. Next slide. So as far as individuals who are more at risk, I put 3 of the main ones on here. So one of them that I put on here is men treated with ADT that Matt mentioned earlier, especially, with prostate cancer. Postmenopausal women, as he said, women usually around 50 or older. And then also women treated with chemotherapy for breast cancer. So a lot of these treatments that you go through will interfere with hormones, and your hormones are very important with keeping bone health maintained. And if it lowers, then it can actually lead to fractures or other bone issues. Next slide. So the why is some treatments, as I said, affect hormones, which affect how your bones form. So bones are constantly being built up and broken down. Osteoporosis occurs when this process is being thrown off and more bone is being broken down than is actually being formed. And the picture that Matt provided earlier and how he described it is very, very helpful. Because if it's just continuing to break down and not build up fast enough, then it's just going to keep decreasing over time, which of course leads to fractures. Next slide. So the first nutrient I want to talk about is calcium. So calcium is a mineral that is required for more than just bone. It's required for your teeth, clotting of blood, normal functioning of your nerves, muscles, and heart. But it cannot actually be made by your body. So it is very important to eat higher levels of calcium to reach your recommended dietary intake amount, which I will get into a little bit later. So as far as calcium, it also cannot be absorbed alone. It has to have vitamin D to actually help with absorption. And I listed some foods that contain calcium, so dairy products, dark leafy greens, fish with soft bone, and calcium fortified foods and beverages, such as those listed. Next slide. And to continue, so some individuals who typically aren't getting enough calcium are vegans, individuals with lactose intolerance, those receiving long-term treatment with corticosteroids, are also individuals with bowel and digestive diseases, so IBD, celiac disease, Crohn's disease, anything that involves a disease that interferes with your intestines. That is where all your nutrients are absorbed. So if they're not being absorbed correctly, then it's not just being utilized quite the way that it needs to be. And usually those individuals just need higher supplementation. And as far as calcium supplements go, as Matt mentioned, individuals who aren't able to get enough calcium through food alone usually have to take supplements to meet the required amount or recommended. There are two types of calcium supplements. There is a calcium carbonate and a calcium citrate. So either supplement is good to take, but if people have issues with acidity in their stomach or they're taking proton pump inhibitors, then a calcium citrate is going to be better absorbed than a calcium carbonate. And individuals without, the issues with lower acidity in their stomach, they can take either type of supplement. It doesn't matter which one you take. They both will get the job done and provide you what you need for your calcium. So as far as calcium goes, I put the amounts for most patients that I see. So as far as men and women, the amounts aren't too different. It could vary just with age a little bit. Men usually require a little bit more later on just because they don't have to go through menopause like women do. And estrogen isn't really as big of a factor. So I wanted to include that. I would say most of my patients, I would do the 12,000 or 1,200 milligrams, just because if you're going through treatments, especially ones that are affecting your bones, I would rather you have a little bit higher of an amount than lower. So for individuals 51 years and older, a limit for your calcium is 2,000 milligrams per day. I wouldn't go above that, especially those with kidney issues, because it can lead to kidney stones, too high of calcium, and or kidney failure. So a lot of my patients too that are going through treatments actually do end up having kidney issues sometimes, depending on what treatments they're on. So it's just really important. I have to factor in a whole bunch of different things depending on what's going on with you and try to make a more individualized diet plan. Next slide. So the next one I wanted to talk about is vitamin D. So vitamin D is required for bone health as well as your cellular functions of your body. Vitamin D, fortunately, is not really in a ton of foods, but you can get it through sunlight in the active form, and that's vitamin D3, or also known as calciferol. And a lot of older adults typically don't get enough of vitamin D just due to lack of sunlight. Sometimes it's really hard to just be outside, especially during cancer treatments. If you have fatigue, just not feeling great, it's hard to get out. So most individuals need to be on a supplement just because most people aren't getting enough. And as far as foods that contain vitamin D, I put examples. Most of it involves fish or fortified milks, fortified cereals where it's been added in. Next slide. So the recommended amount for vitamin D, I would say at least 800 international units, most likely. Just I would go on the higher end. Even in Matt's slides, he had even a higher amount, which is fine as long as you're not going over that limit, which is 4,000, just because it can just get too much in your body, which leads to other issues that can interfere with the absorption of other vitamins and minerals. Next slide. So just to provide a summary real quick. So if you were going through a chemotherapy treatment or other types of treatments for your cancer that affect your hormones, you're going to be at greater risk for weaker bones just because it can be age, it can be maybe your weight, or just how much nutrients you're getting in general. So getting the recommended amount of calcium and vitamin D is very important because it's going to help maintain what bone you have and to help prevent you from losing what you have. And starting nutritional supplements, I would also talk to the doctor who is doing your treatments and all the medications that you are having to take, because sometimes there could be reactions. And so it's very important for all of us to work together as a team just to make sure that we're not going to cause you any harm, because there might be other medications that it could interfere with. So just making sure that you're very open with everything that you have to take with all your healthcare professionals. Next slide. And that's all I have to say. I provided my information on here, and yeah. Thank you.
Laura, are we going to go back? Is Matt back?
Yes, Matt's back, so we'll go to back to him after this.
All right, so we'll wait to introduce Dr. Amy Hudson and we'll let Matt finish up.
Next slide. So I apologize for the technical difficulty. In summary, bone is the most common site for cancerous spread in people with advanced prostate and breast cancer. Bone pain is often the most common sign the cancer has spread. Bone metastasis can be diagnosed with bone scans and other diagnostic tools. Cancer and cancer-related treatment can lead to weakened bones and increased risk for fractures. Prevention of bone metastasis remains a major challenge in treating patients with cancer. And most importantly, safe and effective treatments are available. Next slide. Thank you.
Thank you, Matt. Thank you, Kayla. Appreciate everybody's patience as we get through the technical difficulties, but that's what happens when you have virtual programs. So we're all getting used to that. But now I would like to introduce our last speaker for the night, which is Dr. Amy Hudson. Dr. Hudson works in an outpatient orthopedic setting with an emphasis on manual therapy, lymphedema, cancer rehabilitation, and women's health, and enjoys working with a variety of ages and diagnoses. She acts as a clinical instructor for physical therapy students and assists with continuing education opportunities for new graduates with the company. She has completed her certification in orthopedic manual therapy through Select Medical, is a certified lymphedema therapist through CLOS training, and has completed training in pelvic floor physical therapy through both Herman and Wallace and the American Physical Therapy Association. She has a level 1 certification for Revital Cancer Rehabilitation. Dr. Hudson holds a bachelor's in exercise science as well as a doctorate in physical therapy from St. Louis University. It is now my pleasure to turn it over to Dr. Hudson. And again, put your questions in the Q&A because we'll have plenty of time for all the questions at the end.
Great. Thank you very much, Debbie, for that introduction. All right. So kind of going through some exercise and its impacts on bone, and also giving some specific exercise recommendations. So you can go ahead and next slide. So why do we care about bone health? You know, it's already been kind of talked about a little bit already, but osteoporosis is one of the most prevalent diseases in menopausal women and is strongly associated with a lower quality of life. At menopause, the normal bone turnover cycle is impaired by estrogen deficiency. And then also if female is going through cancer treatment that is kind of further depleting that estrogen, that is also impacting that bone health. The increase in overall bone reabsorption is due to the weakened inhibition effect from less estrogen available. And then there's a higher risk of fractures due to that bone loss. Also, as Matt kind of talked about and Kayla talked about, prostate cancer with androgen inhibition. There's also increased bone destruction, and there's some muscle dysfunction that can also impact that bone health. So also puts them at a little bit higher risk of osteoporosis and then fractures due to that bone density loss. Next slide. So why is exercise important? So impact with walking and weight bearing, it increases that bone mineral density, and it also decreases that fracture risk compared to if you're not doing weight bearing activities. So weight bearing activities are kind of putting weight through your body. Forces, those impact forces, so generating gravitation and muscle loading is slightly better effect on bone metabolism. So we really want to kind of have that force. So you want to have that force generated by both gravity and muscle loading. And then the osteogenic response is stimulated during that resistance training. So that stimulates that bone metabolism and mineral apposition. So kind of trying to help keep what's there and trying to kind of stimulate a little bit more of that bone growth. Okay, next slide. So there's kind of a lot of research that shows strong evidence to support impact exercises such as hopping, jumping, and skipping. Actually in childhood can lead to a higher peak bone mass in adulthood. So pass, not mass, not pass. Go ahead and next slide. So motions. So if someone has osteoporosis that there are a couple movements that we want to be more cautious with, or have that person be more cautious with. So that's spinal flexion, so bending forward, especially if you're doing it repeatedly or doing it with kind of a load or some weight to it. That can cause increased risk of a compression fracture due to the forces on those bones in your spine, your vertebrae. So instead, you'd want someone to do more of a squat down if they're going to pick up an object from the floor, or to do kind of a hinge from the hips, like you're kind of bowing like you're a waiter. Just to avoid kind of, those are some modifiable factors that we can kind of address. So kind of how we move can impact kind of our risk of potentially fracture. And then excessive spinal rotation. So you don't want to force yourself to twist into, especially into pain. And you don't want to be twisting if you're kind of in a really upright position, especially if you're doing a load. Again, just to try to be more cautious, especially if you do have some issues with bone density already. All right, and then next slide. So these are just some examples of some more highly osteogenic activities. So things that are jumping, hopping, basketball, your gymnastics. I don't know if anyone's going to be doing any flips on any balance beams or anything like that, or doing any slam dunks, but just some examples. Next slide. Moderately osteogenic. So it's kind of where we want to be more, walking up and down stairs or running stairs, running, jogging, jumping, hopping, skipping, those kind of things that put a little bit more force through our joints and our bodies is really good. And then next slide. And then there's the more of those low osteogenic exercises, your yoga, your Tai Chi, your very leisurely walking, your non-weighted exercises, not that they're bad, but just don't have as much of an impact on our bone density as some of those other exercises. All right, next slide. So what type of exercise do we need? So there's 4 types of exercise to really address all the areas. So we want to do strength exercises. So strength training, doing that at least twice a week. Posture exercises to try to help get you in a more upright position. So as we lose that bone density, we can to get this more forward position that shifts our center of gravity outside of our nice base of support, which then can kind of lead to an increased risk of falling forward. So to try to combat that or prevent those falls, trying to kind of get everyone in a more upright position. So you want to do those every day. Balance exercises, again, to reduce risk of falling, very important to do every day. And then weight bearing aerobic activity. So that's your walking, your jogging, that you want to try to do more than or equal to 150 minutes per week. So that kind of breaks down to 30 minutes, 5 days a week. And you want to kind of work all major muscle groups. So you can go ahead and go next slide. So we'll kind of break that down into those different components. So strengthening exercises, you can use resistance bands, dumbbells, you can use gravity to kind of help resist your exercise as well. You want to work, like I said, all those major muscle groups. And I'll show some examples in some later slides. And weightlifting actually showed a positive effect on bone mass due to the action of the muscle tendon kind of stimulating that bone tissue. So don't be afraid to grab some weights or resistance bands, because that can actually have a really good impact on that bone health. Next slide. So posture exercises, these are just some examples, and I'll have some pictures, doing some wall slides, basically just kind of getting yourself, again, as upright and straight as possible, working on sitting posture, kind of stretching that chest out. And then, like I said, I'll show some examples of these later on. Go ahead, next slide. So strengthening the back extensor muscles. So those muscles in the back of your body has actually shown to have a significant reduction in vertebral fractures in postmenopausal women, as well as improving that balance and reducing that risk of falling. Like I said, it's improving where your center of gravity is in your base of support. Also helps to reduce the risk of new fractures in individuals who have went through a vertebroplasty surgery if they did have a vertebral fracture due to osteoporosis or cancer also. Next slide. All right, so some examples of some more of those lower level exercises. You don't want to go just gung-ho, you kind of ease into it, especially if you're not used to exercise, or your body's not used to kind of being this really more upright position. So go ahead and click through. So shoulder press, these are some good examples of just kind of getting into that better posture. So pushing those shoulders back into the bed, pillow, towels, shoulder press, kind of pushing those elbows back when you're kind of like we'll call it a chicken wing position. Okay, next slide. Head press, where you're kind of tucking that chin and pushing your head back and kind of having that head press while you're kind of doing a head up and down motion, just kind of working on those neck muscles. Next slide. So these are just trying to get that spine into be more of an extended position. So not everyone can tolerate laying on their stomach, but sometimes using pillows under the belly can help. Kind of doing some extending with your elbows resting on a table to kind of get that mid back kind of straightened out, or kind of bending over back over a low back chair like the bottom picture. Next slide. Some again lower level exercises, kind of leg lifts, laying on your back, belly, and side, kind of working those hip muscles. Next slide. All right, some bridges or butt lifts with your legs propped up on a foam roller, or you could do even kind of like kind of something a little smaller. It kind of limits how far up your body has to lift up. And then that next step is kind of that full bridge where your knees are bent, lifting your bottom up, just gets you into that fuller range of motion. Working that long arc quad is just that kind of a kick out to kind of work that thigh muscle. Next slide. So working again, a little bit more of core and kind of back. Doing Supermans where you're lifting both arms and legs up, or alternating your arm and leg like you're swimming, or doing kind of like a push with your hands and knees together. It kind of tightens up the abdominals and those hip flexors, just kind of adds a little bit of that compressive force. Next slide. So some examples of some resisted exercises. Next slide. So you can do your dumbbell curls, bicep curls, tricep kickback. So working the front and back of the arm, working on kind of doing an overhead press. You can use weight, again, kind of starting off, especially if you're not used to exercising or using weights, kind of starting off lighter, kind of building up that tolerance and gradually building up the amount of weight that you can tolerate using. Next slide. Some examples with some resistance bands, again, starting off in a light resistance and kind of building up, doing kind of diagonal pulls, just kind of working on kind of opening up that chest. Same thing with that bottom one. It's kind of like you're drawing a sword. Next slide. Again, some other pictures of it. These kind of go off of Sarah Meeks. She's the physical therapist who developed kind of a bone health exercise program. So these are kind of some examples of some of the exercises that she's recommended as well. We're kind of doing a bow and arrow pull, kind of using that resistance band going across your body. Again, just a lot of things to strengthen the back and stretch the front. Next slide. Just some more examples, again, kind of building up that shoulder, and then working on even overhead motion, kind of going up and out. By doing that kind of pull, you're kind of working before you go up overhead, you're actually working that rotator cuff and kind of that back of the shoulder a little bit more. Next slide. All right, so some weight bearing exercises. Next slide. So you can put weight through your arms on a wall. So you're kind of doing a push up against the wall. You can also kind of push against the wall as you're bringing your arms up and down, like you're doing a snow angel. Next slide. doing some squats against the wall. You don't necessarily have to do against a wall, but the wall sometimes helps just give you a little bit more support or kind of a cue of your form, kind of like you're sitting down in a chair, kind of having those arms out, kind of doing a little slide up and down like you're doing and making a W. That works that kind of those shoulder stabilizers. Next slide. Heel raises, going up and down on your toes. You can also do toe raises, kicking your leg back, kicking your leg out to the side. Again, you're putting weight through your body when you're doing this, which is good for that bone health. Next slide. And then some more progressive exercises. So these would not be things that you'd be starting with. You can be laying on an exercise ball and kind of doing a lot of things to, again, work on those little stabilizer muscles in the back and then stretching the front. So doing kind of Ys, Ts, and then Ws with kind of working those shoulder blade muscles. Next slide. So one muscle that I always like to talk about because it's kind of the forgotten muscle. So the diaphragm is not only our main breathing muscle right under our rib cage, but it's also an important stabilizer. So that diaphragm muscle contracts or tightens before we do any kind of overhead arm raising, overhead flexion of our arm to help stabilize our spine. And so one way that we can kind of work on just figuring out to get that muscle working and kind of being aware of it is to practice diaphragmatic or more belly breathing 1 to 5 minutes every day. Okay, next slide. So kind of just showing an example of where that diaphragm is. It's right under our rib cage, right at the bottom of our lungs. So when we inhale, that diaphragm flattens out and our stomach expands if we're breathing correctly using that diaphragm. And then when we exhale, that diaphragm kind of goes back under our rib cage a little bit more and our stomach contracts or pulls in. Next slide. So flexibility is also important. So the muscle groups that we want to be kind of mostly aware of is kind of stretching that chest or pectoral area, because that helps with that kyphotic or kind of rounded forward posture. If we kind of stretch that out, it kind of helps bring us up more upright. And then that gastrocsoleus, so that's kind of that calf, those calf muscles. We want to have good ankle mobility for gait or walking, just so that we don't trip or toe when we're walking, and then tripping can lead to a potential fall. Next slide. So these are some things to kind of work on doing some of that stretching or flexibility. Leg lengthener kind of stretches that back of the leg, and you're kind of working on the muscles in the front of your shin, your dorsiflexors that help kind of bring that toe up when you're walking. Arm lengthener just kind of helps to stretch kind of the body out a little bit, get you in that more upright position. Next slide. And then again, some more examples of some flexibility. So kind of just stretching that chest. You can do that on a foam roller. You can do it on a ball. You can just do it like tightly roll up some towels and put it along the spine. Just kind of help give you a little bit of extra room to move, depending on if you're really stiff, might just be laying down is enough to give you a stretch if you're laying flat. All right, next slide. All right, and some ways to kind of stretch that calf. You can have your hands on a wall or a chair and have the back leg is the one that will be stretching, or you can always use like a strap to assist you. Next slide. Balance exercises are also important. So kind of going up and down on your toes and on your heels is good. Standing one foot in front of the other is called tandem. Standing on one leg, because we do stand on one leg when we're walking. So that's always important to have that balance. Walking heel to toe, like you're walking a tightrope. Standing on varying surfaces. So not always something super flat. We don't always walk on flat ground. So some, grass is uneven, rocks are uneven. So kind of working on a variety of textures, like pillows, cushions, foam, things like that. And then Tai Chi is actually a good kind of exercise to work on balance as well, kind of those slow fluid movements. Next slide. And then these are just some examples of some of those standing and balance exercises. Next slide. and a little bit more, just so you have a visual idea of what they look like. Next slide. All right, and then aerobic activity. So talked about, that's also an important component. So walking about 20 to 30 minutes every day, or 20 to 30 minutes a day, about 150 minutes per week. You can break it up into shorter intervals if needed, even up into like 10-minute intervals. You want it to be a moderate into vigorous intensity. So if the RPE is rate of perceived exertion, so a 10 is like impossible, like you're done. 5 to 8, so you're going to be breathing a lot heavier, you're going to be maybe sweating a little bit or glistening. You know, it's going to be a little bit more effort, but it's not going to completely wipe you out. And that activity should be weight bearing, you know, especially to have that good positive impact on bone health. And next slide. And then that's that rate of perceived exertion, so you can kind of see where it should be at. Kind of that between that 5 and 8, so somewhat hard to hard is where you want it to be. And next slide. And then some special considerations. So if you're unable to lay flat on your back because of pain or another health issue, you can always have your legs propped up on a chair or a roll, or so you're kind of in more of that 90-degree position with your hips or your knees. You can also have a pillow under like your breastbone or your pelvis if you're laying on your belly. Yoga and Pilates, just kind of if you go to a class and you do have some issues with bone health, just make sure that you make the instructor aware that you have osteoporosis or osteopenia, so that they can give you some appropriate modifications to prevent excessive that spinal flexion. Next slide. And gym centers, so you want to avoid kind of those like abdominal crunch sit-up machines, knees to chest, anything that really puts you in that more forceful flexed position, and just making sure that you know to kind of how to properly perform an exercise and adjust that weight accordingly, and make sure that the back is supported and stable to protect your spine. Next slide. And those are just kind of some of the resources that I used. And that is the end of my presentation.
Unmute myself. Thank you, Dr. Hudson. We really appreciate it. And I just want to thank all of the presenters tonight. We are going to turn it over, or I'm going to turn it over now to Danny Hodges, who is going to moderate the Q&A. And I believe you got several questions in the Q&A entered, and we had quite a few sent to us before tonight's program. So I will turn it over to you now, Danny.
Great. Yeah, we do have quite a few in the chat now. I'll go ahead and start with those, as some of the earlier entered questions may have been answered somewhat during the presentations. I will still try to hit them to make sure everybody gets their questions answered. But we'll go ahead and start with this one. Amy, this will be a question for you. A great question. Can the rebounding trampoline help or replace hopping, jumping, and skipping?
Yeah, that would be a good alternative if someone enjoys it, because you are putting some force through it. Having some of that ground reaction force when you're doing it on the ground is also helpful. So if you can do kind of a little bit of both, that'd be good. But if that is something that you enjoy and that is kind of giving you a little bit more of that force, that is an option.
Great. And while we're talking about exercise, here's another great question. This person is 62, and they're taking a medication that I'm not sure I can say. It's Orgovyx, ORGOVYX, and they're 1 year into androgen deprivation therapy after occurrence of prostate cancer. So they're running and bicycling, but is that enough to maintain bone health, or would it be beneficial to add weights?
So definitely adding weights is going to be also helpful. Doing some running and biking. Now, biking's not going to kind of give you that weight, that force production through your joints, but running is great. So doing some weight training, a couple days a week, kind of working those major muscle groups is going to be also very helpful. Just kind of maximize that bone health, and then making sure that you're kind of seeing a provider to kind of monitor, where your bone density is at, and kind of making sure that kind of it's maintaining while you're doing those things as well, while you're on that medication.
Great, thank you. Now, we have a couple of questions here. They're different, but they both relate to hormones. So I will go ahead and ask the first one. So in the absence of estrogen, what hormone promotes bone production? It's probably a good question for you, Matt.
Yeah, so bone formation occurs primarily, oftentimes, like Amy was talking about, the osteogenic loading. So putting force through the bone. It's not necessarily derived from a hormone per se, but when women, for instance, become postmenopausal, or men become hypogonadal, decreased testosterone, or decrease in estrogen, the body's ability to protect from bone loss is gone. So when women become postmenopausal and they stop producing estrogen, they start to lose bone very rapidly. And the estrogen protects from bone loss. Hormones don't necessarily stimulate bone growth. The weight-bearing exercise does, depending on which treatment that is being used for the osteoporosis. There are medications that can build bone just from their pure nature. There are medications that are what we call anti-resorptives. They slow down bone turnover in an effort for the body to build up the bone. So the problem is the decrease in the hormone subsequently increases the bone loss, which puts people at risk.
Okay. Now, you may have touched on this in your presentation, but I will ask this question. What hormone deficiency are you talking about as far as bone deficiency? What hormone is lacking when you're talking about bone deficiency?
Yeah, estrogen in women and testosterone in men.
Okay.
And then subsequently the treatments related to some of the cancers suppressed those even further. And so natural aging, you typically lose those over the course of time. But then when the cancer treatments are administered, that bone loss becomes more rapid because of the depletion of those hormones that I mentioned.
So if your cancer is hormone dependent, how often should you have your bone density tested post-cancer treatment?
Yeah, I'm not sure that there's necessarily a guidance with regards to whether the cancer is estrogen or hormone related as far as the timing of bone density. The timing of bone density should be based upon those risk factors that I mentioned. If you already have those predisposing risk factors, if you already have those age criterias, then you should be getting bone density testing. And typically it's every 2 years. However, if you are on chronic medication that either is expected to build your bone or suppress your bone, most insurances will cover it every year. And I frequently get that conversation when I order a bone density at 1 year for particular patients who are on particular treatments. And they say, oh, we know that it only covers, it's every 2 years. It's not true. If the correct documentation occurs and you've expressed why you are doing it, and there's a code that can be used for chronic medication management or long-term medication management that you would expect to see a change in bone densitometry, that's the appropriate coding and information that insurances should cover without any challenge.
Right.
But if a baseline bone density is determined to be, or that there's a deficiency or evidence of osteoporosis already, then that also alters. Because if you're going in with low bone mass and then you're starting treatment, that bone loss may be more rapid. If you're perfectly normal when you start, maybe you don't need it every year. Maybe every 2 years is appropriate, depending on which treatments and therapies are being rendered. So it's a little bit nuanced, but it's usually every 1 to 2 years.
Okay, thank you. So this one, Matt, you might want to touch on this, but also Kayla. What meds can a breast cancer survivor take to ensure that the bones are strong if they have osteoporosis, but they're already taking vitamin D?
So as far as medications are concerned, well, as Kayla and I both mentioned, calcium and vitamin D are the basis for anything we do. Calcium is best consumed in your diet. Unfortunately, a lot of people don't get the necessary amount of calcium on a daily basis. And what I encourage all my patients is to do a calcium diary, where for a week or two, they actually write down how much calcium they're getting. They look at the labels of all the stuff they're eating over a week or two, kind of based on what's their normal dietary intake and how many days of the week do you get to that 1,200 milligrams. If you find that you're routinely not getting to that 1,200 milligrams, then supplementing to make up that difference. But, unfortunately, a lot of people don't get a lot of calcium. They're not dairy consumers, not a lot of green leafy vegetables, salmons, nuts, things like that. And so they have to supplement with calcium to get their entire dose. But beyond that, the question about the medication, again, it's about risk stratifying, and not everybody's risk for fracture is the same. And I tell everybody, lots of providers treat osteoporosis based on a bone density, which is unfortunate. That's not the only way to treat it, and probably not the best way to treat it. Stratifying someone's risk and determining what is the best treatment based on that risk, there are levels of robustness. There are medicines that will build bone in 1 year equal to 7 or 8 years of the lowest robust medicine. So there's a big extreme with regards to the ability to build bone over the course of time. And so it's very important to risk stratify each patient. If you are on multiple medicines that put you at risk, plus you are a smoker and alcohol user, steroid user, history of rheumatoid arthritis, you can imagine that the risks mount very quickly and your risk for fractures. But in orthopedics and in all bone health, we should be trying to prevent fractures. Those are the most devastating complications associated with this chronic disease. And so much like when we try and put people on blood pressure medicine and cholesterol medicine to prevent a heart attack, we're trying to prevent bone attacks. A fragility fracture is a fracture that occurs when you fall from standing height or less to one of the long bones, or fractures related to cancer. And so these fractures are tremendously predictive of future fractures. So it's important that when those fractures occur, someone should be talking to the patient or the person about, look, this is the first red flag warning that there's going to be more to come if we don't do something to address the underlying bone health issue.
So a little follow-up question on the calcium. Can you actually get calcium from dark leafy juices, or is it actually better to eat the vegetables?
So every dietitian, or most dietitians, would say it's preferable to eat the vegetable more than drink it. So even if you're getting the juice would have some in it. But if you think about, let's say celery has all those ridges and all these like little, it's almost like a plant basically, like if you look at a flower. And so they have all these little cells on the inside. If you take those away, those actually have a lot of nutrients in them. So if you're just taking the juice, but you're not getting the rest of it, like example, like an apple, if you have a pill on an apple, but you unpill it, that you're losing nutrients that way too. So if you want to get the full benefit from having those, I would suggest eating it in its actual state more than taking the juice from it.
Fascinating. Okay. We are going to shift gears again here. There are centers like OsteoStrong that have you do maybe one single rep of a really high weight for bone strengthening. But then this person said they've also read about some injuries. Any thoughts about those types of exercise routines?
I would say I've fairly intimate experience with OsteoStrong, and I do think that there is some beneficial component to the program with regards to osteogenic loading. As Amy and I both discussed, there's a phenomenon that happens when you put a force to bone, it stimulates formation to make stronger bone. For instance, if you know someone or have known someone who is quadriplegic or paraplegic, they lose bone density very, very quickly. There's something called disuse osteopenia or disuse osteoporosis. And when you're not, like for instance, someone who has a recent fracture to the leg, they're not bearing weight through there. It doesn't take very long to see changes on an X-ray of the bone density slowly absorbing. And so that it doesn't take a lot of disuse. And so with regards to those machines, you are applying force. You can still do the same things by walking. Walking is one of the best weight-bearing exercises that you can do. Some resistance training, doesn't have to be heavy. You can do some light weights, doesn't have to be heavy. So, and if you look at all the best research about OsteoStrong, it says that it's best in combination with traditional therapies and treatments for osteoporosis. But I can promise you, much like everything in life, there's risk. I know people personally who have done the wheelbarrow lift and suffered compression fractures. So depending on the severity of your osteoporosis, depending on the type of cancer you have, if it predisposes you to, metastasis, or you already have metastatic disease, it wouldn't take a lot of force to put a fracture through the skeleton. So, risk has varying degrees. I tell people all the time in my clinic, the most dangerous thing that any of us will ever do statistically is get in a car and drive up and down, and I point out the window at 70 and 270 whizzing past our hospital. But statistics are numbers, and at the end of the day, there are oftentimes the human sitting across from us that we have to make real decisions about. But I think the relative benefit of OsteoStrong is good, but it doesn't come without risk.
I agree. It's probably not the best option for every person, but it can be a great option for certain people. And just making sure, again, kind of weighing that risk benefit, and making sure that if you're doing an exercise that your form is correct to try to reduce risk of injury. Because if you're loading your body, but your form is not appropriate, you're going to not get that maximal benefit, risk injury, or even worse, you could set yourself up for potential further worse injury of like a fracture, depending on what you're loading and how you're moving, or where that movement fault is. So could be helpful, but is it far superior or inferior to other things? I'm not sure that I can say that for certain.
Okay, great information. This person asks, do you know anything about vibration plates for bone health? My understanding is that they're specific frequencies, direction of force for safety and efficacy. There's also a wide range of prices.
So from what I've read, I don't know that there's been really strong evidence to support that it has, a superior impact on bone density compared to those things that we've talked about. So I don't know that I would say, yes, everyone needs a vibration plate, and maybe Matt can also talk on that, with his experience as well. But, I'm not sure that it's a necessary piece to it.
I would say that I think there's a little bit of mixed information. There have been some research studies that suggest that there is a positive benefit to vibration platforms. I think if we consider all of the therapies that exist, again, much like the medications, there are levels of robustness and levels of extreme robustness that occur. And, every little bit probably helps, whether or not you're hopping on a vibration platform daily and then doing regular weight-bearing exercise and taking supplements and taking pharmaceuticals. That's going to have the most robust impact without question. The likelihood of harm associated with a vibration plate would be incredibly small, unless your teeth are rattling at the same time, and then you probably ought to back off the vibration.
All right. This person says, prior to cancer, my bone density level was very strong, above normal. What can a person do once they have completed treatments and DXA shows bones are now considered osteopenia?
Yeah, so much like the conversation about the cancer-induced bone loss or the cancer treatment-induced bone loss, it doesn't take long. Just statistically speaking, in a traditional postmenopausal female, when you become postmenopausal, you can lose up to 1/3 of your bone mass in the first 5 to 7 years. So you can imagine, depending on which time point you are being diagnosed with cancer or which time point you are being offered cancer treatment, in that process, you can accelerate the bone loss very quickly. Traditionally, we think about building bone. The key bone building years are between the ages of 8 and 18. And I always refer, when I get an opportunity to talk to kids, you're building your peak bone mass, which is your bone savings account. We know that some kids, for instance, poor nutrition, poor exercise, lots of negative things as far as their diet or intake. For instance, in women, there's something called a female triad where they work out a bunch and they stop having menstrual periods. They don't build peak bone mass. And so if you never build that peak savings account of bone, you are already going to be at risk, because between the ages of 18 and 35, there's a plateau. But then at 35, bone starts to trickle. Bone loss starts to occur until you become postmenopausal. Keep in mind, postmenopausal can occur for a lot of reasons. It can occur naturally, it can occur surgically. And if you don't do something to supplement estrogen or the hormones after you become postmenopausal, then that bone loss can occur very rapidly, like we discussed. So the timing of the cancer diagnosis and the subsequent treatment is going to have a tremendous impact on that conversation. But it's not surprising that you could have normal bone density at time point A, and then over the next 5 years with cancer treatment and the cancer itself, have bone loss that would represent osteopenia.
Okay. So we have a couple of questions here that refer to specific types of medications. So I'll kind of read them back to back here. We have one that says, do you feel that taking Zometa helps prevent breast cancer from metastasizing to bones? Can a low dose be taken as a preventative without the bad side effects that I've read about Zometa?
So this is a great question. And we do know that there are medications that can help to reduce the incidence of bone metastasis. They're typically anti-resorptive. So let's take a step back. There are two different types of medicine groups that can be used to treat osteoporosis. There are anti-resorptives and there are anabolics. The anti-resorptives slow down bone turnover in an effort to build bone naturally. There are anabolics which physically build bone just by their pure nature. And so Zometa happens to be one of them, or zoledronic acid is the generic name. There's another medication called denosumab, which comes in two different forms. One is typically given to cancer patients in a much higher dose on a much more aggressive regimen than it is for just traditional osteoporosis. But there is good data that supports that it can prevent or reduce the risk of metastatic disease. And So I do believe there is good medication, and I do believe that there are different safety profiles related to both of them. But statistically speaking, all of the medicines used to treat osteoporosis are incredibly safe.
Great. So a couple more medication questions here. Does tamoxifen really help bone density?
So bone density, maybe it's worthwhile to mention that bone density, while it is the gold standard diagnostic test before fractures start to occur, is a good surrogate to measure or determine someone's risk for fracture. So it's important. There's a rule of thumb. Don't worship at the altar of bone densitometry because there's a lot of nuance to it. And so it's part of the picture, but it's not the be all end all. And so tamoxifen, while it is at the bottom of robustness for incremental increase in bone density over time, you may see some subtle change over the course of a few years of bone mineral density. So to answer the question, yes, you would expect that there may be some improvement, but it's at the bottom of the robustness list. So I wouldn't expect profound increases, but again, that's where there's a nuance in treating osteoporosis and bone health. Lots of people get caught up in the numbers game of a test instead of treating the human across from them. And so it's important to take into account the other risks when considering treatments and therapies.
Okay. Someone just started taking anastrozole. Is there anything they can do to offset the impact of bone loss while taking that specific medication?
There is. A lot of the anti-resorptive medicines are indicated for patients who begin the aromatase inhibitors to prevent bone loss. There are a couple of medicines that are specifically indicated for bone loss related to cancer treatment. So yeah, there absolutely is. And depending on the length of time in which you anticipate someone to be on that medicine, the aromatase inhibitor, how soon you initiate treatment is dependent upon that length of time that you intend for them to be on it.
Okay. And one last medication question here. Is there any information on negative side effects from medications like Prolia, Reclasp?
Yeah.
Those two medications?
Yeah, so those also are anti-resorptives. They tend to be the two most robust anti-resorptives that exist. And so, for instance, one of the most common side effects associated with Reclast is the first dose that patients receive. They may experience flu-like symptoms for up to a week after the injection. It's an acute phase reaction associated with that. It's historically the only time that occurs. And so I always encourage patients, while you may not have had the most desirable experience for that first week after your injection or your infusion, that the likelihood of you having a subsequent experience is almost non-existent. Once that happens, most people tolerate subsequent infusions very well. With regards to Prolia, it's incredibly safe statistically. If you look at, and I always encourage patients when you're evaluating a medicine about safety profile, that last little blurb they spit out on the commercial on TV is oh my God. But if you actually look at the placebo, meaning somebody took nothing, and somebody who took the drug, and compare the side effects that are reported, there's almost no difference. And so if you're not fearful of taking nothing, then you may not want to be fearful of taking something because most of the drugs, there's almost no statistical difference between people who didn't take anything and people who did take something. So to comment about the side effects, Prolia is tolerated extremely well. I can tell you that I have tremendous experience with Prolia, and I see it's now been on the market. I think this coming June is 13 years, little to no side effects.
Okay. All right, we have time for this one last question that just came in. So this will be our last question. And in fact, we got through all of our question lists. So this is fantastic. So quickly, what are some yoga poses that should be avoided when your bone density decreases?
So anything that really causes you to be in that very flexed spinal position. That's not to say that you can't do downward dog, because that's more kind of that hip hinge, kind of elongating the hamstrings. Now I will do the caveat of I am not a yoga enthusiast or a yogi, so there's probably a lot of different poses that I am not aware of. But again, kind of those things that kind of have you do repeated kind of flexion or bending of the spine, and or kind of doing a lot of twisting of the upper body when you are standing. Now, if you're going to do that, just kind of smaller motion, don't go to the extremes. If you're starting to feel some discomfort, don't force it. Listen to your body. If you do have very poor bone health or bone density, then I would definitely just avoid that spinal rotation. If you're kind of osteopenic, I don't think that doing a yoga pose with spinal rotation, if you're not going to those extremes, is necessarily going to, result in anything negative. And Matt can definitely correct me if I'm wrong. But if unless you're, again, in kind of those more, you're doing it repeatedly or going to those extremes, or if your bone density is really in a poor shape, then those are kind of those precautions or limitations we want to follow.
Wonderful. Thank you. This has been a fabulous question answer session. So I want to thank all of you for bringing your questions to the panel. And I want to thank the panel for giving such amazing answers. Thank you. That was very informative. And I'll turn the time back over to Debbie to wrap things up.
All right. Well, again, I ditto what Danny said. Thank you so much. And the Q&A is I always find that so fascinating to sit through those. Just so you know what's going to come next, tomorrow you are going to receive an email that will have the contact information for all of the presenters tonight, as well as Sharsheret Supports St. Louis and the Cancer Support Community. So you'll have a way to reach somebody if you want. We are going to drop a link in the chat. I believe Laura's going to go ahead and do that. It's for a survey, a post-event survey. It'll take less than 5 minutes if you have the time to stay and take care of that, because we're always looking for ideas on how we can share information and help support and educate. And if there's things that you would like to see us do differently or in addition, we definitely want to know that. We'll also put the link in the email that you'll get one tomorrow afternoon as well. So if you don't want to fill it out now and you can fill it out later, that would be great. Again, I want to just say thank you to all of the presenters, because not only did you join us tonight and answer questions, but you took the time to prepare, and we really appreciate you and your partnership in this. So thank you so much. And then I just hope that everyone is leaving feeling a little bit more empowered and walks away with a little bit more information. And we appreciate everyone taking the time to be here. And Danny, thank you. It's been wonderful partnering. So the two organizations, it's been a lot of fun. So we appreciate everybody.
All right. Thank you, everybody. Have a great evening.